Okay. So good afternoon, everybody. First of all, thank you very much for the invitation to both the organizing committee and the EMPODA committee to invite me to take part in this conference. I think this is the first online conference that EMPODA is organizing. And in this difficult moment, I think it was a very good initiative because at least as a podiatric community, we still managed to meet and to share our research. I think now we are nearing the end of this conference, and today we have seen a number of presentations which were all very, very indeed interesting. From my end, I will be presenting some of the research which we have conducted here at the University of Malta with regards to research on vascular assessment. So basically, in clinical practice, caring for patients generates many questions about the diagnosis, prognosis, treatments, challenges we healthcare professionals all have every day with regards to our patients. One approach in trying to meet these challenges, obviously, to use evidence-based medicine. Finding the gaps between what we do every day and scientific research is obviously of utmost importance if we are to offer best patient care. So what is the purpose of a vascular assessment? So peripheral arterial disease is an important complication and contributes to a lot of morbidity in diabetes. Evidence indicates that early detection of PAD will result in fewer ulcerations and amputations. And we also know that the vascular status of the lower limb bears a direct relationship to tissue viability. Furthermore, the severity of vascular disease has been associated with an increased morbidity and mortality rates. So risk identification is fundamental for the effective management of patients with high-risk feet. A thorough vascular assessment is crucial in order to try to stratify our clients. So what is it? What is the importance of a vascular assessment? What will it tell us? So a vascular assessment identifies whether the blood supply to and from the lower limb is adequate for normal function and tissue viability. It will help us identify the vascular problem. Is it arterial? Is it venous? Is it both? To what extent is the vascular problem? So this will help us in order to monitor our patients and to also try to predict further complications such as infection and ulcerations. It will help us identify whether there are any vascular abnormalities which could affect healing or our treatment choice. And it will also help us to decide whether we need to refer our patients to other specialists if the problem cannot be tackled from our end. As podiatrists, there are various modalities which one can use with regards to vascular assessment. So there's pedal pulse palpation, measuring temperature, starting from simple temperature gradients to now very sophisticated thermographic cameras, spectral Doppler waveform analysis, the measuring of ABPIs, the measuring of toe pressures and TBPIs, and the use of transcutaneous oxygen measurements, TCPO2. So as I said in this presentation, the aim of this presentation is in order to try to pass on the message that although there are a number of tools which as a podiatrist we could use in order to try to assess, diagnose peripheral arterial disease, one needs to be very careful. Because as you will see, especially from this one of our latest publications which we have published, one needs to be very careful when interpreting the results, especially when used in high-risk populations, such as patients with diabetes, smokers, patients with rheumatoid arthritis, etc. So this first study, we aimed to compare different screening modalities in the detection of peripheral arterial disease. We conducted a prospective non-experimental comparative study in various primary health centers. We had a number of exclusion criteria like people with edema, people with amputations, history of DVTs were all excluded from our study. So basically what we did, we recruited 50 participants living with type 2 diabetes using a convenient sampling method. Obviously, the room was controlled for temperature and humidity in order to avoid vasoconstriction of the arteries. Participants were asked to rest in the supine position and to acclimatize to the room for about 20 minutes. Pulse palpation, waveform analysis, ankle brachial pressure index, absolute toe pressures, toe brachial pressure index, and transcutaneous oxygen were all compared into detection of peripheral arterial disease. We included 100 limbs for analysis. Excuse me, because something happened. Okay. So from our results, and I will pass on to my next slide so that you would understand even better, we found that depending on which modality we were using, we detected different percentages of people presenting with or without peripheral arterial disease. So say if a clinician had to be depending only on pulse palpation, in our study, we would have found only 23% of our participants with peripheral arterial disease and 77% of the population without peripheral arterial disease. However, if the clinician was using a Doppler, one would have found 93% of the population presenting with PAD, with only 7% not having PAD. So here you can see the big difference. Same goes for ABPIs, the absolute toe pressures, TBPIs, and the TCPO2. So the study demonstrates that inconsistencies exist between the agreement of 6 different widely used modalities to detect PAD. As authors, we presume that one possible reason for the increase in both minor and major amputations, which we are seeing worldwide, could be ultimately this incorrect diagnosis of PAD due to the inconsistency exhibited between these 6 widely available tools. We therefore recommend that practitioners should not rely on the use of only one testing modality, but should use more than one test. And when inconsistencies between testing modalities occur, then obviously one needs to try to find other tools and other gold standard methods in order to determine whether or not that patient actually has PAD and most importantly, the severity of that PAD. Other research which we continued to conduct all show these same results which this study has concluded. In another paper which we presented in Diabetes Research and Clinical Practice, again here our aim was to compare the ABPIs to Doppler waveform analysis. We conducted again a prospective study, including 49 patients. PAD was assessed using the documentation of intermittent claudication, rest pain, palpation of pulses, and as I said, pedal waveform analysis and ABPIs were measured. And again here, if you look at these 2 tables, okay, if one looks at the ABPIs, one can say that using the American Diabetes Association classification, a clinician would have diagnosed those patients, okay, with normal ABPIs. However, if a clinician was relying on spectral Doppler waveform analysis, okay, according to the guidelines provided by Norgren et al., there you will see that you would have classified your patients having either mild or severe PAD. So again, this is quite worrying, okay? The next table shows the same thing, but obviously for the left foot. But again, results are very similar. So conclusions again for the study. Combining Doppler waveforms and measurements of the ABPIs yields more reliable results without significantly increasing the time required for testing. As authors, we again recommend that when results do not concur, further evaluation should be performed. This time we also conducted a study, this time among smokers, okay, because we wanted to see whether we would get the same result. The other populations were patients with diabetes. And again, the study investigated whether daily tobacco smoking affected peripheral arterial disease in a cohort of middle-aged individuals. We had 20 smokers and 20 non-smokers. And once again, our results confirmed that there was no significant difference in the ABPI scores. However, there was a significant difference in the Doppler waveform analysis on all the arteries assessed between. It is also very important to determine the correct vascular status of our patients prior to amputations. So once again, we conducted a study, this time in a population prior to undergoing minor amputations. So the aim of the study was to identify any significant difference in physiological tests between healing and non-healing amputation sites. We aim to speeds, APIs, absolute toe pressures, TBPIs prior to the amputation, and then we reviewed our patients again after 6 weeks in order to determine, okay, whether their vascular status actually could have shown us whether we were going to have healing or non-healing in that amputation site. So again, once again, our results showed that there was no significant difference in the ABPI measurements between the healed and healing and the non-healing groups. However, TBPIs and ankle spectral waveform analysis did give an indication of which were those patients which were more likely to heal than those who did not. So again here, this study, okay, concluded that toe pressures, spectral waveform analysis are better predictors of the likelihood of healing and non-healing after minor amputations in the diabetic foot. And again, we recommend that peripheral arterial perfusion should be assessed using different physiological tests in order to help us come up with the decision of the process of. We conducted another study, this time amongst patients presenting with living with rheumatoid arthritis. Again, the aim of the study was to determine the manifestation of PAD in a population with RA. Okay, we used again the same modalities, basically, as I said, spectral Doppler waveform analysis and ABPIs. And once again, as you can see here, results indicate that whilst ABPI index was normal in the majority of the participants, waveform analysis was suboptimal in approximately 1/3 of our sample population. So, and then we wanted to do another study. So we wanted to actually see, so because we have seen a lot in all these studies that spectral Doppler waveform analysis seem to be good predictors of PAD. However, we wanted to test the numerator reliability of spectral Doppler waveform analysis. And we did conduct another study here amongst 5 experienced podiatric physicians at the University of Malta. A researcher who was not a rater in the study actually selected 229 printed spectral Doppler waveform analysis, which we have in our database. And each rater independently rated the qualitative spectral waveforms. And in our study, we did find that we found a high inter-rater reliability in visual spectral Doppler interpretation amongst experienced clinicians. Okay, and so we can conclude that if these are interpreted correctly, this information provided can give us a good indication of the presence of arterial disease and facilitate, obviously, early management of this very, very important condition. So, to conclude, early diagnosis of PAD permits prompt commencement of secondary risk factor control, which is known to delay long-term complications, improve outcomes, reduce the financial burden which this condition imposes on both the individuals and the healthcare system. The goal can only be achieved by ensuring that healthcare professionals are well informed, and I hope that with this presentation we have convinced you as clinicians to be careful, okay, which tools to use when you are screening or diagnosing PAD. And as authors, we always emphasize that most importantly, a clinician will not rely only on one test and one piece of equipment, but as much as possible use different diagnostic tests to come up with a right diagnosis. Thank you very much.